Garson Roberts. I got married, so my name is a little different. I work on orthopedics. I've been a nurse for a little bit over a year. I went back to school after my children were born, and I raised them to a school age level. I'd always wanted to be a nurse, but I didn't know. I put my family first. I became a nurse at the age of 34, which is daunting to anybody, and now you've all figured out my age. So, I've been at the hospital for just about a year. I work on a med-surg floor. I work on orthopedics. With that being said, we get a lot of patients who choose to be surgical candidates. They come in for knee replacements and hip replacements, and they come in with an expectation and a care plan, and they have to take a class. It's very intensive to have this surgery done. In order to get out of bed, it takes 2 people the first day. There are many times where we don't have 2 people to assist to get patients out of bed in a timely manner. We also serve hip fractures, any bones that have been broken that require surgery and an overnight stay will usually come to our unit. We also serve as a surgical overflow, so we receive patients who they have like bowel obstructions and appendicitis, gallbladder surgery. So, to give you an idea of what we go through I work overnights. So what we go through on a nightly basis is there are usually 2 nurses. Specifically, I'm going to speak about a night that I worked with Leilani. We came in to 3 admissions back to back to back. And getting admissions is a time-consuming ordeal. You have to collect their history, you have to assess them, you have to settle them into their beds and make sure that they are comfortable and well taken care of. Usually overnights, they will have family members with them, so you're also assuring family members that their loved ones are safe. Doing those admissions takes time, so this one particular night, there were call bells that were unanswered for at least 15 minutes, which I don't stand for at all. Usually people ring their call bells for toileting or pain medication or things that you take for granted. Like, I just would like some water and I can't get up to get myself water. I need to use the bathroom and you need to help me use the bathroom. Making these patients wait even 5 minutes is asking a lot on them. So unfortunately, we were unable to get to our patients in a timely fashion. And this is more and more frequent where we are pulled in so many different directions because not only are we responsible for admitting patients overnight, doing an assessment on each of our patients to make sure that there are no changes in them from the beginning of our shift to the end of our shift. Surgeries are a big, scary thing, and many things can go wrong. Your blood pressure can drop, your stomach can get blocked, you can have an ileus. We need to make sure that those things aren't happening, and in order to do that, we need to get in a timely fashion and make sure that we know what their baseline is and we know if there's been a change. And unfortunately, it does happen, but it comes at a cost. I know for myself, I don't use the bathroom when I'm working, I don't drink water, and my patients are being cared for, but it's taking a lot more out of us. So we're asking for your support. We're looking for more staff. We're begging for more staff. Thank you.
Thanks, Sarah. So my name's Leilani Colburn. I've been a nurse at Berkshire Medical Center for approximately 3 years. I've been a nurse overall for 4. I also kind of started late in life. I think nursing is really a calling. And thank goodness it called for me. So I had the good fortune actually at Berkshire Medical Center to work in several different units. I started out in the psychiatric unit, Jones 2 and 3, and I can speak a little bit to each one of those, and I think that's what I'll do, because there's nobody here on the panel from psychiatric. So I also work the night shift. Newer nurses are generally working the night shift. Those are what's available. I would work a 9-hour shift. I'd come in, you are the only nurse sometimes on a floor, specifically Jones 2. You are the nurse, you have 2 nursing assistants, and you can have up to 20 patients. That's daunting. On Jones 3, you can have up to 15 patients. There is a float nurse, but because Jones 3 is generally a more critical floor, that nurse does tend to stay in that area unless she's needed down on 2. We have patients who come into the emergency room. They're off the hook. They need help, and they come to our floors. They have weapons. They are lashing out at us. Some are detoxing. So to have a single nurse on that floor overnight is scary. Recently, I was floated back to that unit to fill in, and I hadn't been there in 2 years, so I hadn't done a charge position in 2 years. Charge being the person who's, kind of coordinating the floor. I thought I was just going to be a second nurse, and I was put in charge on Jones 2, 17 patients. They had a patient fall on the evening shift. She was in C-spine. Anybody here that's a nurse knows C-spine on a psychiatric floor is almost impossible. How will I move this person? It takes 3 people to do C-spine, and I am myself and 2 nursing assistants. What about the rest of the patients? I just kind of an overall. I transferred out of there. I felt a little unsafe. Security is good, but there's not enough of them. 1 code gray sets you back. A code gray is an incident where a patient is acting out, and security and all hands are on deck to try and calm the patient. 1 code gray takes security right out of the picture. So if something else happens, you're essentially on your own until that code gray is complete. I did transfer to orthopedics. I needed a med-surg experience. I love the orthopedic floor. It's like Sarah said, people are generally there, they're happy, they're getting new joints. But I also worked the night shift. I was oriented to charge. Charge nurse is a person who kind of orients the floor. They keep everything running smoothly so that the other nurses can do what they need to do. Unfortunately, on the night shift, that charge nurse has a full group, generally anywhere from 5 to 6 patients, and then you have to deal with the short staffing. There's no ancillary staff. We share a unit secretary with 5 other floors. 3 other floors. We have no unit, nursing assistant. Generally, we have no nursing assistant on the floor to help us with post-op vital signs, which are quite frequent, and just ambulating people, getting people out of bed, getting them to the bathroom safely so that they're not falling out of bed and risking their health in a different way. So I essentially left orthopedics just thinking, wow, I'm so overwhelmed. I'm feeling like, holy cow, I don't know if I can do nursing anymore. I went to the critical care unit and I thought, well, if I'm gonna make it, this will be the unit. It's a make it or break it for me. It's the highest level of care there is. I do love it there. In the intensive care unit, you have the protection of the law. You have an ICU law. You are limited to 1 to 2 patients. It depends on the acuity of your patient. So for instance, the things that happen on the intensive care unit on a regular basis are our charge nurse on the night shift gets pulled. So she could get pulled to anywhere. She could have to go to a code blue, which requires her to leave the floor. She could have to go to a MET team, and that's MET teams throughout the entire hospital. Sometimes she even just gets a phone call from a concerned nurse saying, I don't feel like it's a Met team, but can you just come and look at her? Can you just come and look at my patient? And she does. So on this particular night, we were crazy busy. I had a 2-patient assignment. Everybody around me, the 3 nurses around me, had a 1-patient assignment. Those are 1-to-1. It's you and your patient. They are critically ill. We had the charge nurse get pulled. She had to take an assignment, and what ended up happening was she left her assignment. She went to a Met team. That Met team person came to the floor. Because our charge already had a group, that patient came to the floor, no nurse. Critically ill, no nurse. The 3 people around me with their 1-to-1 patients dropped everything they were doing to take care of this patient who needed to be intubated emergently and who was bleeding out. Those people left their patient assignment. I can't leave a 2-patient assignment. We had enough nurses in the room for that patient coming up, but guess who gets to take care of those other 3 patients? I do. 5 patients on a critical care unit. It's scary. We need more help, and on top of that, there are times where I have worked 3 or 4 or 5 days in a row, and my first day off, I'm being called to come in. Can you come in? Can you work any part of the shift? Can you work any part of the weekend? Can you come in early? Can you stay late? Those are things that are being asked of us on a regular basis. You miss your meals, you miss your potty breaks. Who will take care of the nurse? We have to make Berkshire Health Systems accountable for the care of their nursing staff, or else who will take care of the patient? Thank you.
My name is Sandra Vosberg. I'm a nurse in the Maternal Child Health Department at Berkshire Medical Center. I work the day shift. I've been there for 32 years. 25 years in maternal child health and 7 in critical care. I also feel very blessed to be a registered nurse. On the maternal child health unit, I work as a labor and delivery nurse. And in that role, I often roll into the expanded role of the charge nurse. And in that role, you oversee a number of anywhere from 5 to 7 nurses in an ideal situation with a full floor. You oversee the nursery and the postpartum patients, and you work as a team member in rounding on every patient with every doctor, for every baby, every pediatrician, because we have obstetricians and pediatricians. There's a lot to cover in that couplet of a mother and a baby. And in the charge role, you're expected to be a resource for every nurse on that floor, for the ancillary staff, for any abnormal occurrence that occurs on the floor. They're going to go to the charge nurse on what is the next step. I enjoy that role immensely. It can be overwhelming. We had a clinical leader who was a permanent charge nurse on our floor for at least 30 plus years. And she retired. 3 other nurses retired with her, all within 2 months. We lost some of the best nurses who delivered a majority of the babies in Berkshire County in the last 30 years. And it was a huge loss to us. They have yet to post or fill that clinical leader position. Therefore, our staff absorbs that 40 hours work and is expected to be in charge of the entire floor and have a full patient assignment. It's a very difficult task. We have junior nurses that are 6 months on the job. They continue to need support for at least a year to be a fully seasoned labor and delivery nurse. We experience losses on our floor that are extremely consuming of hours, emotions, and care. We have premature babies on our floor that require transfer, emotional support, once again, to the parents, critical intervention to save these preterm babies' lives, very, very specialized certifications, and good communication with the outside staff. We have an opiate addiction problem in Berkshire County. We often have at least 3 withdrawing babies in our census daily on the labor and delivery unit. Those babies sometimes stay 3 days minimum. On the long term of things, up to 3 months. They receive morphine. Their mothers receive support from us. We work with DCF to help keep these mothers and babies together. We try to control heated emotions when DCF comes in and tell these people they cannot any longer be with their baby and they need supervised visitation. How are we to help these mothers recover from their health crisis, learn to care for their babies, medicate their babies to keep them well and alive? Withdrawing babies cease. It's not an easy task to control that. And we support these mothers. We do everything we can to provide their bonding, their teaching, their nutrition, their psychological support, their social support. We often give them shirts that we keep of our own in our lockers to give them clothes to wear, because they come in many different conditions, have their babies prematurely, and have nothing to stay with. We need to support our public. We need to help these babies become well, keep our mothers together with their babies. Mothers right now, in this day and age, are much older. It's a wonderful thing, but they're much sicker when they're carrying these babes. Hypertension, diabetes, drug opiate addiction are just the beginnings of how our healthcare has changed in the years. And we do a wonderful job on the mother-baby unit because the nurses work their tails off to support our patients, our families, our grandparents, our pediatricians, you name it. We work to the end of the spectrum to care for them, but we don't have enough staff to support them without getting tired, without getting overworked, and not feeling that we're not doing them the justice that we would like to do. So I appreciate you all coming. I'm sure between children, parents, grandparents, these stories touch you all as they touch me. And thank you for coming.
Can everybody hear me okay? My name is Amber, and I work on critical care and critical care step down. I will talk about the critical care step down because Leilani gave a good overview of the ICU. So the types of patients that we get on our floor are all different types. We get ventilator patients, which are patients that have a tube in their throat to help them continue breathing and give them that type of support. We are getting patients that need very, very high doses of oxygen. And with our opiate and alcohol issues now, we're getting very, very intense detoxers. These patients are very, very dangerous. People have gotten concussions from these patients, injured. They end up having to go to the ER to get treated because of this. It's a scary thing for a lot of the newer nurses that come to our floor because we do get float nurses, which are nurses that float around the whole hospital and are not our core staff. We also get MET teams, which are, as Leilani was explaining, a charge nurse goes to the other floors for patients that meet a certain criteria. So their blood pressure could be elevated, their O2 saturation could be dropped, their mental status could be changed, which is they're not thinking or able to communicate and they're just not acting themselves. So we'll get these patients in crises and we have to come together to take care of these patients. So our floor can be a little crazy at times or a lot crazy at times. And we do get a lot of float nurses on our floor that don't have the specialty skills that the core nurses do have. So they're limited to the jobs that they can do on our floor. So they need a little bit extra support from the core staff, so it takes a little bit of time away from our 4 patients that we usually have. So we can make them comfortable in the job that they're coming up to do with us to help us out on our floor. I also wanted to talk about our bargaining sessions. Most recently, after we have taken the rejection vote and the strike authorization vote, we've had about 4 sessions maybe, and in those sessions in August, I think each session we have met with management a total of maybe an hour out of a 9-hour day. They have refused to bargain with us over the staffing issue. Constantly we're hearing, well, you still have this on the table, you still have this on the table. Because it's important to us. It's important to all 794 nurses at BMC. The one thing that they did offer to us was a staffing committee, which is only effective to them after our contract is signed, and they still have the final say on any issues that are brought up. They say that it's giving the nurses a voice, but that voice is already what we have now to bring up concerns. It doesn't have any teeth. It doesn't take them to be accountable for their actions, for not staffing the hospital appropriately and safely for the patients to get the care that they need. So that is my story. Thank you.
Hi, my name is Mark Roeder. I work in post-anesthesia care. I'll tell you a brief situation that we run into occasionally down there. Post-anesthesia care is probably one of the better staff units. We always have a core number of staff, no matter the number of patients. Occasionally you run into a situation, probably about a month ago, I had a patient, and simple procedure, easy recovery, and another patient came in. We had a whole bunch of patients who were waiting for beds on the floor. There were no beds. They didn't have the staff to bring the patients upstairs. So the patients were being housed in the PACU. So then the time comes where the evening shift comes in, so now they have the staff. Those patients can now go upstairs. So, and they have to be transported by a nurse. So the nurses are bringing the patients upstairs. There's 2 nurses left. I have 1 patient, I get a second because there's only 2 of us in the PACU at the time. The other nurse has a critical patient. She takes a second patient. And then all of a sudden 2 more patients come out. So there's 2 of us. Total of 6 patients. My patients are all right. I go over to the first patient who's sort of obtunded because of the medication. They're not able to support their own airway. So in that, I mean, like their tongue kind of slides in the back of their mouth and closes off their airway so they can't get air from their mouth into their lungs. So simple maneuver, you just lift up their chin, opens up their airway, and air can get in there and they're fine. And they breathe on their own. And you're able to support that very easily, very minimal intervention. While I'm holding this person's chin up, I am with the other patient that just came in trying to get rapport on this other patient. Meanwhile, while this is happening, my first patient is now over the rail throwing up all over the floor. And I can't leave the patient who can't support their own airway. So I can't help the person who's currently vomiting all over the place. And not only does that affect me as a nurse not being able to provide the care that I'm obligated to provide and I want to provide as a caring person, but also that patient is uncomfortable, they're throwing up, they're going to end up being there longer. And those situations in the post-anesthesia care usually last for a very short amount of time. We do have crisis staff, which is a nurse that floats around the hospital, a very high level of care, can work in a whole bunch of different units. That's kind of the backup plan, but it's a backup plan for the emergency room, the ICU, all of the floors, the PACU. So at the time, that nurse was in the emergency room with a trauma. They couldn't leave. So it left us with no backup plan, and we're left in a situation where we're not able to be in more than one place at a time, which I think is a common theme with all of the stories. We're saying we physically cannot be in more than one place at a time. You have 3 staff, one person holding somebody's neck because they've fallen and they're worried that there's a break, and you don't want the person to become paralyzed. So it's very important to have all those staff present. So those 3 staff are in the room, you only have 3 staff on the floor, somebody else's call bell's going off. They have to go to the bathroom. They no longer can wait, then they try to get up on their own and fall on the floor, and then that comes back at us. But we're saying that it's not possible for us to be in a room holding somebody's neck so they don't become paralyzed and help that person to go to the bathroom at the same time. I'll tell a very personal experience that I've had at the hospital. My mother had surgery, a fairly routine procedure. She recovered in post-anesthesia care, went up to the floor. As soon as she went upstairs, I went home to go take a nap because I had to work that evening. I called probably about an hour later, and her friend was still there, and she was just saying she didn't seem right. So whenever somebody says somebody doesn't seem right, to a nurse that kind of sets off a flag. You might not be able to put your finger on what the problem is, especially if you don't work in the medical field, but you know there's something wrong. So I drove back to the hospital just to check it out, because if somebody says something's not right, you have to address that. So I went in the room. She was unable to lift her head up off the bed. She has no medical problems or really past medical history, generally very healthy. Unable to lift her head up off the bed, white as the sheet, severe shoulder pain. Her blood pressure was 80/40, which means she doesn't have enough pressure in her system. I'll tell a very personal experience that I've had at the hospital. My mother had surgery, a fairly routine procedure. She recovered in post-anesthesia care, went up to the floor. As soon as she went upstairs, I went home to go take a nap because I had to work that evening. I called probably about an hour later, and her friend was still there, and she was just saying she didn't seem right. So whenever somebody says somebody doesn't seem right, to a nurse that kind of sets off a flag. You might not be able to put your finger on what the problem is, especially if you don't work in the medical field, but you know there's something wrong. So I drove back to the hospital just to check it out, because if somebody says something's not right, you have to address that. So I went in the room. She was unable to lift her head up off the bed. She has no medical problems or really past medical history, generally very healthy. Unable to lift her head up off the bed, white as the sheet, severe shoulder pain. Her blood pressure was 80/40, which means she doesn't have enough pressure in her system to perfuse, to get blood to her organs, to her brain, to make sure everything's properly working. And she's telling her friend, just go home, I just need to rest, because my mom doesn't complain. I then went to go to the secretary, asked, who's taking care of my mother? Where are the people? So it turns out both of the aides, one was floated to another floor, the other one was pulled to sit. So there were no nursing assistants. Had there been anybody to go in the room and look at my mother, they would have immediately seen the problem. They would have silenced the alarm, be able to see that her blood pressure was going down, her heart rate was going up. The nurse that was taking care of her, a very qualified nurse, skilled nurse. She had 6 patients on the evening shift, 3 of which were fresh post-op. She was settling in a post-op. She could not be with my mother and a post-op at the same time. There was no one to alert the nurse that there was a problem with my mother. There were no nursing assistants, and the charge had a full assignment. So the charge was on the other side of the floor, taking care of all her patients. So there was no backup plan. There was no ability for that nurse to be in two places. So I pulled the nurse out of the room she was in. She came, just looked at my mother, did lab work. She got transfusion after transfusion, rushed back to the OR. It turns out during the procedure, they nicked an artery in her abdomen. So she was bleeding out in her abdomen, which is a risk that happens when you have surgery. But it's identified in things like altered mental status, not thinking clearly, change in skin color, change in vital signs, things that nurses look at every day, if there is somebody available to actually see those things. She was rushed back to the OR, they fixed it, but then she ended up in the ICU for a week and a half. This was supposed to be a procedure for an overnight stay. Had it been caught earlier, all of those things could have been avoided. She wouldn't have had to get unit after unit after unit of blood. And with every unit of blood somebody gets, there's a risk associated with that. With every procedure, there's a risk associated with that. So with all of this delay, with a completely qualified, great nurse who was unable to be in more than one place at one time, my mother had to go through all that. All these things occurred to her. That could have been avoided if she had the person present. If there'd been a charge nurse without an assignment, who could have just been like, oh, that's beeping, let me go check out what it is. If there'd been a nursing assistant to go in and say, oh, I see that her blood pressure is changing, I should alert the nurse. If there had been anyone available, and had I just gone to bed that night, I wouldn't have been there to go get the nurse and bring her in the room. I don't know how much longer that would have gone on and how much longer my mother would have lasted. So it's just it is scary, but it's a real example of a risk that patients are put in. And as nurses, we have a union, and we have a protected voice that allows us to say we need help, we need to do something. We cannot work like this. It's not fair to our patients, it's not fair to our community, it's not fair to our coworkers or ourselves. I think that with the examples that we've all shown before, it's clear that even though we do excellent work, we skip our breaks, we don't eat, we don't drink, while we're taking care of your loved ones, your relatives, your neighbors, and we do it because we love it and it's important to us. But we're saying there's a point where we can't be there as the safety net. It takes away our ability to advocate for a patient who might need that extra help, or who might not have their current needs being addressed, and they might need somebody to speak up for them. I think that there is also another thing that we've seen in several other communities where community members get together, they form a group, and they say, these are things that our hospital needs. This is a community hospital. It's a private institution, but it really belongs to the community. It is there specifically to take care of all of us, our family members, when we're at our most vulnerable, when we're not able to speak for ourselves, and having some sort of community group that might help increase your voices to say, I want my family member cared for in at least this level of care. I don't want my family member to be ignored or not have the services they need because there wasn't somebody there to speak up for them. So if anyone is interested in being on any sort of community board, maybe at the end, in the back, you can sign up, something like that. Just let us know. That's it for me. Thank you.
I'm Ella Mary D'Agostino. I live in Crossway Village in Lee, and I'm up in the beautiful Berkshires 12 years from New York. I am a certified nurse assistant, and yes, it is a calling. I am retired and continue to care for the frail elderly in their homes. I am shocked that this is even, I don't know what to say. Who in the Commonwealth should be correcting this? How can they say they're 5 stars? Do they really think they're going to replace you if you go on strike? I do think you need to go on strike for the sake of the patients.
The real issue is our partners in the MNA are not able to do the job they were trained to do. I work at BMC. Many of the nurses come to Berkshire Community College, and I know that they're taught to do things effectively and in a very patient-centered way. Well, if you've got 20 patients on the night shift, and you've got 3 new patients and everyone else is taking patients upstairs, that's just not helpful. I don't want my hospital to be that way, and I don't think anyone else does either. So just raise your hand if you'd like to speak and come right over. Sir.
The bargaining process, and I'm just wondering, first of all, how do you, I've heard all of your stories, and obviously they're very compelling about specific situations where there have been inadequate staffing. So from your point of view, how do you determine what adequate staffing is, and what is the hospital's position? Are they refusing to bargain on?
We started out asking for, the hospital has set grids for every unit, pretty much, that says if you have this number of patients on your floor, you should have this number of staff. That's determined by our hospital administration. So we started with those, and we made slight improvements. So if in one group, on one floor, if 13 patients, you needed a little extra help. So we tried to ask for some improvements. Then we went down and said, how about you just be accountable to what you have determined is safe through our administration? They said, absolutely not. We cannot be accountable to that. And then as the year has gone on, we have asked to not include grids at all. But just to say, how about you make sure that our charge nurse has no assignment, so they can be that extra set of hands. If there is a patient on the floor that's all of a sudden decompensating, getting worse, and needs that extra level of care until the appropriate people can arrive and stabilize the patient. Or you get an admission, the charge nurse can settle that patient in while the nurse is hanging her antibiotics and doing things with her other patients, just so that way it gives some relief to the nurses so they can actually provide the care that we want to provide, that the patients require us to provide. They've all paid for their insurance and paid into Medicare for their entire lives. They have paid for us to provide a service. And we're saying we're not able to give them the service that they have paid for their entire lives. They deserve it. Our patients deserve to be well cared for, just at a basic level. So having that available, so far they have offered either no counter proposal or the staffing committee, but they took out any sort of part of the staffing committee that would hold them accountable. So they'll say, yeah, we'll talk to you, but we have the final say. If you don't like that, then we'll have the final say again, and then it'll be over. They want to give us a voice, but the voice won't go anywhere. It won't be anything more than what we have now. So safe staffing, really, we would just like them to be accountable for what they have determined is already safe. Research shows that we could do better, but we would be all right with what they've already determined is safe for now.
Steve Raden, Pittsfield. It's my understanding not only is there a shortage of nurses, there's a shortage of registered nurses as well. Is it because the hospital just saves money not hiring more nurses, which obviously it does, or because there just aren't enough nurses out there that are trained that the hospital can hire? Is there a shortage of population?
I think in New England, we probably have one nursing school per person, because we have so many. That's an exaggeration. But, so we have a lot of nursing schools. VCC turns out great nurses every year. Retaining them, the nurses, is difficult for us. I know that the ICU has lost tons of nurses over the past 3 years. They just keep leaving. So the environment has to be one in which will keep people here, have people stay here, want to raise their families here. Right now, we don't have that environment. We don't have the level of respect. Being chronically short is exhausting. To not only work in a profession where you give everything for your patient, but then you're taking care of more patients than what you say you can already do. And then you also don't have a nursing assistant to help you. I mean, the nursing assistants they play a vital role in what we do. And they provide care and free us up to do assessments and administer medications and respond to emergencies. But it feels like almost every team within BMC is short. It's not just the nurses, it's the nursing assistants, nurse anesthetists, respiratory therapists, clinical therapists. So they should really be making an effort to attract and hire and then retain these qualified staff. I know several people who have been qualified people, years of experience. They apply at BMC, they call, they don't ever get an answer back. So there are people trying to get jobs at BMC, but then they never get a response. So I'm not sure where the breakdown is, but we need people. We know that there are plenty of nurses, even physically local to the area.
I'd like to add, when a full-time employee leaves Berkshire Medical Center, they take that position and break it into a 16-hour and a 24-hour part-time position, which requires no medical benefits and saves them money. And my unit feels that especially. And where are you going to find someone who needs a full-time job and will work 2 days a week? And how are they going to improve their skills and remain current working 2 days a week? So that also prevents us from being able to support each other, or the union being able to support us to get more help.
Other questions or comments?
Hi, my name is Len Yost, and I'm going to make a comment and then try to get some clarification. I think it's a confusing situation that we're dealing with here. It doesn't make sense to me. I've been in the Berkshires 30 years. I'm in the healthcare field myself. And each August, the Center for Health Information Analysis publishes financial reports for every acute hospital, all 63 hospitals in the state. And at the end of August, this comes out. And BMC made $47 million last year. The year before, they made $46 million. So they've made $93 million in the last 2 years alone. I don't see how this really can be a financial issue, because it seems like there's money to take care of the nursing staff, which in turn obviously takes care of the patients in the community. So I'm confused as to why this has even come about. Why do nurses have to even threaten a strike for a hospital that's profitable? They're rated 8th or 9th rather in the state for overall profit, meaning, and the hospitals that are ahead of them are like Mass General, Brigham, Beth Israel. They're rated 9th in the state. They have almost a 10% profit margin. This is not a struggling hospital. This is not a hospital on the verge of bankruptcy. I don't understand how the board of trustees for the hospital, they should, I don't know if they do, but they should have some information. Come to, and my unfortunate reading of this is, I think the hospital administration initially took a very adversarial stance with the nursing staff. We're not going to be told what to do by our nurses, of all people. And they've got a lawyer, Diane Patrick, who's taking the same position, that they're out to win at all costs regardless of what it does to the hospital, the community, the nurses, patients, and it's coming to an unfortunate outcome here because the nurses, I believe, are in a position where they can't accept this any longer. You go into fields like teaching and nursing for a reason, to help the people, but you, like you said, there's a bottom line that you can be pushed past, and the nurses, I think, are far beyond that point. So it wasn't a question or a statement, but again, it's an unfortunate situation. It's a small community hospital, and the position a hospital is taking is to demean you as people, question your integrity. You've got 2 nursing administrators saying these reports aren't accurate, these 430 reports can't possibly be accurate. It's just like, it's a bizarre situation where they're paying for radio ads, billboards, they're supporting the Eagle with advertising. Why don't they put that
aren't able to be at the bargaining table. I'm not on the committee itself, but I go to bargaining on a regular basis. And to be in there, it's absolutely infuriating. You're treated like children. You're basically scolded for even trying to get something better for your profession and for your colleagues. I have never experienced anything like it. I just leave there dumbfounded sometimes, but everything you said is exactly true. This is a not-for-profit hospital. Their margin should be used to better their staffing, better their facility, not buy nursing homes in the greater Boston area. So those are for profit. So I mean, there's no doubt there is money in the well, and you know, they'll be hard pressed to say at the table that there's no money to be had, because then they would be required to open up their financials to us. So I think, you know, they're playing both sides here.
Hi, my name is Jim Lipa. I'm from North Adams. I'm a member of the North County Cares Coalition. And we really at North County can understand what it must be like dealing with David Phelps. Good luck. He has not listened to a single word about what the needs are in North County. They refuse to even engage our community about what needs to happen. But my concern, the closure of the North Adams Regional Hospital, what effect did that have on the nursing staff there, and how did that increase the burden? And did BHS ever address that at all?
I'll answer it as briefly as I can. Since North Adams closed, we have been asked to care for the North County population. You don't have an acute care hospital in North County. You can go to Vermont or you can go to BMC. And more often than not, ambulances will not take patients outside of the state. They come to BMC. They have a satellite emergency facility that cannot care for a higher level of ill patients. And that's not to say that we don't try. Yeah, they triage them and then send them to BMC. So we are inundated with sicker patients, more patients, and we don't have the proper staff to care for those patients. So we have taken on every patient that had gone to North Adams. They come to us now. Fairview is only that's a tiny hospital as well, and they come to Berkshire Medical Center as well. So really, BMC is the be-all, end-all of Berkshire County. There is no other place for you to receive care, unless you go to Albany or Springfield. Thank you.
My name is Frank Farkas, and I'm here representing the Berkshire Democratic Brigade, and we are solidly behind you 100%. Mark has come and spoken to us. I was very, very impressed by your presentation tonight. I knew things were bad. I didn't know they were that bad. And what's remarkable to me is the terrible role that the hospital administration has played. They've tried to split the community against workers in the hospital. There are ads in the paper. They're suggesting that nurses are trying to destroy the hospital because nobody wants to use the hospital. Absurd. You know, you've shown tonight your compassion. You care about patients. Your needs are our needs because we will eventually, all of us, be patients at one point or another. I wanted to call attention to something that happened in California early in the 2000s, I think around 2003. The state legislated limits on ratios of patients to nurses. And the result has been tremendous. They said that nurses have a better working situation, the morale is up, there's less turnover, there are less readmissions of patients to the hospital. So in the long run, it probably saves money to have to be adequately staffed. Do you agree with that?
And just to give you a better understanding, I left BMC in 2008 because staffing was a problem. So obviously they haven't fixed anything, they haven't listened to any of you nurses. So I took an $8 an hour pay cut and got a wonderful job. Loved my new career, and I will stay there. I get coffee because I came in a snowstorm. I fell in the BMC parking lot because it wasn't sanded and lost my whole Dunkin' Donut coffee, and nobody gave a you know what. Didn't even give me a cup of coffee. Didn't care. I said, you better put some salt out or you're going to lose more nurses and you can't afford it. This is not a new problem. When I was there, we were doing acuity. You had to write down what the acuity was for your floor at the time. It didn't matter. You didn't get more staffing because you had more acuity level. Nobody cared. When I left, my very last day, I overheard the person, who's the vice president or whatever now, say, if she thinks she can find a better job, let her go. I'm sure it was said so I could hear it because I was right down the hall, so I couldn't miss it. I did go, and I'm proud that I went. I have to be careful. I have relatives that work there, so I don't want anybody getting in trouble. But it has always been a problem. It is not going to stop until these nurses finally strike. It is time for you to walk out and tell them no more.
Mary Ann Hicks. I recently retired, but I'm per diem now. The one thing I wanted to mention is a lot of people, maybe even in the rooms, in the room here, may not have been around when the other strike happened in 1981. I just want to mention that it's not easy if we do it, and it's going to require a lot of community support. So I would ask any community members that are here, if that is something that comes down the pike, that you stay behind the nurses, and it's we're going to need a lot of support. So that's it.
I've been a nurse for 22 years, 10 of them at Berkshire Medical Center. And I just wanted to say that I'm proud to be a registered nurse, and I'm proud to work with the people that I work with. It's very hard to feel like you're a team player when you can't help each other. You can't save each other from going under because you're going under yourself. But it's not for lack of trying. We succeed in spite of BHS and their management, or lack thereof. And I just want to say that we're missing an unsung hero, and it's our family members. Our family members suffer because we're suffering. I come home and I'm stressed and I'm tired. I miss family events. My husband works Monday through Friday. We get 4 days off together a month. He gets woken up every weekend I'm off. It's ridiculous. If there isn't a staffing issue, don't call and ask me to come in.
Yes, my name's Dick Casati, and I'm from North Adams also, and I'm a member of the North County Cares Coalition. And I just want to echo what Jim said. There's no doubt in my mind that the CEO and the other administrators at BMC don't want anybody to tell them anything that they don't want to hear. We've had that experience. You know, we've been able to try to advocate with the Attorney General's office, and one of the things that we were able to suggest to them is that if you're a nonprofit in the state of Massachusetts, that there be some requirements. That one, you'd have one person that works at that nonprofit as a voting member on the Board of Trustees. Number two, that no one who works at that nonprofit can make more than 7 times the base salary of the lowest paid person at that facility. I think that they need to start listening. If they're going to hide behind behind this nonprofit when they keep pulling in $42 million in surplus a year, getting enormous salaries from both the hospitals and from their nursing homes. They're separate. If someone gets paid $582,000 in 2013 plus $1.8 million put into his retirement fund, that was just from the hospitals. It didn't count all the money he got from the nursing homes too. So we're aware of this, and people are sick of it. I mean, they're the 1% in Berkshire County. You're dealing with the people that are suffering. You see the suffering. They don't come close to the salaries that these people who are denying you your voice at your workplace, they don't even come close to that salary. These people have to realize where they are. So I'm with you. I support it.
My name's Erin. I'm a nurse in the ED here in Berkshire Medical Center. And we see short staffing every day. Every day, almost every day, we start with 6 active nurses who work at the bedside for 30 beds. This is an emergency department that is not staffed for emergencies. We have had times we've had no nursing assistant in the department for up to 4 hours. They are the ones who pound on your chest when you need CPR, while the rest of us are pushing meds and getting lines. They are the ones that help those to get on the bedpan and to get to the restrooms. Otherwise, they have to wait until we can get to them. Everyone has a job, from the housekeeper to the doctor, and we're all short-staffed. You can tell if you really look who's answering the phones. We're short in secretaries, which means when you have a trauma and one of your family members has a trauma, there's not many people to call or answer the phone. When you are bleeding out, there's not very many nurses to help you get the blood you need. So it is a true issue in the emergency department on most days with low staffing. And we've been begging and pleading for more staff. We have people leave. We've had a big turnover in the last 3 years. Very few have been replaced. The ones that have been replaced have been per diem, so they get to say when they work and when they don't work. And when we need them is when, weekends and holidays is the toughest. And then the overnight staff. It's hard to replace those people too. We lost up to 9 people. That's a whole shift on a weekend. So we feel it, and I know you guys feel it. You see yourselves waiting in the waiting room 4 to 6 hours. Sometimes it's because we're full, and sometimes because we don't have enough staff to fill the beds. So I just wanted to share that with you. I was late getting to the meeting, and I wasn't sure if it was mentioned or not. So.
Hi, my name is James, and I happen to be married to a nurse, Marie. We won't use last names. I just want to take a little history tour with you. In the 1990s, we had a fellow named John Johnson, was it? Who were in the hospital. Just throw that name out, look it up if you don't know about it. But my wife worked really hard when we were having a second child. We sat down and did the numbers. Would it be better for Marie to go back to school and work part-time somewhere? And I worked and not do daycare. We made that choice. The difference at that time was about $40. So we felt having a stay-at-home mom was a good idea, and Marie would do her thing. I had never seen anybody so interested in the education that they were getting. We were working on our house with a big wall in the kitchen. And on that wall were mathematical formulas, statistics, and that stayed there for 4 years. But part of this journey I want to get into is I was really amazed when we went to work at Berkshire Health System at BMC. And there was a program that David Phelps had instituted. He spent tons of money sending people to the Elms College. Actually having the Elms College come to Berkshire County and paid instructors. And they put together an RN program specifically for BMC, for the nurses at BMC. And certain people went and took that course. And I think GPA was 99.8 somewhere. That was the average GPA. They had never seen anything like it. And they built a community just around that educational experience. And I said, here's a forward-thinking guy. He's working with the community, he's building relationships. He spent a ton of money, but he's going to get payback from it. Because all the nurses, male and female in that group, they're all still in medicine as far as I know. Some have moved on to bigger jobs or to maybe another hospital. I'm not really sure of the reason. But when I couple that with the ad on the radio, with the two women talking about some nameless father who was afraid to come to the hospital. But they talk about the millions and millions of dollars they're going to lose by having the strike. And then I look at the cost for each registered nurse for a year. Now, if you have $4 million to spend at the Berkshire Eagle and on radio ads, and I'm thinking, how many nurses is that? How many nurses' aides? How much of a raise could you give people? To take better care of the community in which we all live and work. And it's hard for anybody to get me the answer to this. Who actually owns this hospital? Who built it? Who funded it? Who supported it? Who were the people actually put the bricks and stone together? And I think these are things you should remind Mr. Phelps of. These nurses are highly educated. They're skilled in science. They've been taught the things you ask them to learn to come here to work. They know what they're talking about.
I work in a setting of neonatal intensive care, labor and delivery, preterm labor, and we strive very hard to follow the recommendations from the A1 Nursing Association and the NACOG. It's a recommendation that is listed for physicians and nurses. When you become certified, you become specialized in your field of care. And just like the ICU safe patient law, we try our best to follow the more recent associations, A1, NACOG, because they are specialized for more high-risk situations, and Berkshire Medical Center administration just hasn't come with the times yet for that specialty focus. They think a nurse is a nurse is a nurse. And there are many specialties that they feel nurses can be floated from pediatrics to a med-surg. I will give you an example. I was in charge on the maternal child health unit. Pediatrics is a floor of the past at Berkshire Medical Center. They only open when there is a child in need that they can staff for. Many pediatricians in this area prefer to ship their children to Bay State Medical Center or another center for care, because there is often a delay in care at Berkshire Medical Center to get that child to the pediatric unit. The pediatric nurses are floated to the med-surg floors, and they have a full assignment. It takes at least 45 minutes to an hour, which was exactly how long it took last week to care for a child in an asthmatic emergency. The ER was held up holding on to that child because the pediatric nurse, who is specialized in children, had to give up a 5-patient assignment on a medical floor. They have been promised us that that nurse would be readily available to care for a child at any time of need. And the pediatrician came to me demanding why was it an hour's length of time till that child got to the pediatric floor. So there's a huge part of our society that is treated very poorly just for the sake of having a sick child and having a local place for your child to be cared for. BMC supports shipping a child to another area and putting that stress on a family to care for their baby or children out of this area. It's a shame.
So are you saying that staffing ratios sometimes need to be quite specialty specific?
Absolutely.
So it's a complex question. It's not that have 4 patients in the nurse hospital-wide.
Right now, on the mother-baby unit, when staffing calls for our census, they do not care whether a mother is in labor, delivered, or in preterm labor, or a fresh cesarean section. They are all one patient. And laboring patients require much, much more than a delivered mother. And people just don't understand that in our administration.
We have another.
Thank you.
I have to tell you that I'm new to being a part of the committee, and I was wide-eyed and bushy-tailed. I wanted to solve this issue. I wanted to come in with some fresh ideas, work with management, and say, let's do this together. Let's make this better. Part of this process has been very painful to me and very eye-opening. I'm so upset related to upper management and how they've treated the workforce at BMC and how they've tried to demean and degrade the work that we do within the community. But I am so blessed to see all you people here supporting us that aren't nurses and our family members. With respect to your question related to what the ratios are, we have tried to put forth so many different ways to solve this staffing issue because there's no one certain way to do it. Every unit is different, every unit is unique, and we want to be that type of staff that can be pliable and be workable. We are not trying to do something to make the hospital bankrupt, financial difficulty. What we're trying to do is care for the people in our community who we love, our family, our friends, our coworkers, our children. So what we have put forth to management in all different forms, in all different arenas, has been shot down. They refuse to hear any form of bargaining related to workload, which is a big, big issue for the nurses and other staff member at BMC. And hopefully, us fighting for this will trickle down to everyone else and it'll help that workforce be more effective. The fact of the matter is, and you've said it and you've read it and what you've printed out, better quality care, the nurses at the bedside able to give care and take care of the patients, the mortality rate decrease. The patients do better. We see it, we know it. I came from ICU, I worked with such strong men and women on ICU. I am lucky to have their support and to be taught by what their skills have given me. To bring that into other areas and to see how it's not just one area that's affected, it's every single place in that hospital. You work in the ED and you think, this is awful. I'm short-staffed again today. This is the emergency room. We have to have the staff to deal with an emergency situation. When you have a stroke or a cardiac arrest or a child that needs surgery and you don't have the staff to do that, I go home in tears listening to these stories. I'm affected by it. I left the ICU because I was so upset because I couldn't care for my patients the way that I wanted to. So it's not a monetary issue. It's not a Boston-based issue. This is an issue at Berkshire Medical Center that we've been dealing with for a very long time. And we're willing to make amends and try to work with the management. They have blatantly disregarded anything that we have given to them to try to work. We said, okay, you don't want the managers to have, or you don't want the charge nurses to have an assignment? They're absolutely not, we can't do that. How about we do this? How about we have specialty nurses that we can train to be the catch-all? They'll cover some, they want no part of any bargaining related to that, and they have to. They have to.
I was a New York City school teacher for 38 years till I retired. And in New York City, we were told almost identically what you were told. They listen to you, you say, I think you need to do this, and here's why it's good. In our case, here's why it's good for the kids. In your case, here's why it's good for the patient. And their answer was, no. So we said, well, how about this? This other thing is a good thing, and here's why it's a good thing. All those good things would have cost the city, or actually Mayor Wagner considered himself the city, it would have cost him money. So the answer was always no. Eventually, we decided they weren't listening to us. No matter how often we asked them for things that were quite reasonable and gave them the reasons why they were reasonable, they just said no. There was only one way we were going to deal with it. They had to know we were serious. We were not joking, and it was going to cost them. It was going to be serious. So we went out on strike. One day. That night, the mayor found $38 million. It isn't that they don't have it, it's they don't want to let you have it, and the only way you're going to get it is by being serious. We had to get serious. Now, that didn't end it. It got us many of the things we wanted that night. But 6 years later, they tested the waters. Are these people still serious? Do they really mean it? And we went out again. It took longer than one day. But again, we were serious. And then they were convinced. And they never had to be convinced again through all of my years of teaching. It's terrible to go out on strike. You've got to get a bunch of your staff to be willing to do it. In our case, it was 10%. Out of 38,000 people, we got 3,800. Now that doesn't sound like a lot, but it shut the schools down for a day. So they just couldn't run them. Now you can't shut the hospitals down. I don't know how you work. Or maybe you can. I don't know. I don't know how it works. Well, but you guys will know. But you're not going to get things that are perfectly reasonable unless you get serious. Thank you.
I think part of the problem, and I may not understand this thing, and you guys have to help me out a little bit here. My impression is that that hospital is overburdened with administration. If you want the money to hire more nurses, which you desperately need, and I agree with you, somehow the administration has got to recognize that and find that it's more painful not to have the nurses than it is to get rid of some of the staff that they have there. Now, I'm suspicious, and maybe you can answer this question for me. I've seen pictures, I never believe any of the advertising coming out of the hospital. I don't believe a word of it hardly. But there's one that haunts me because they've used it now 5 or 6 times that I've seen in the Berkshire Eagle. It's a picture of all these wonderful nurses standing around because they're responsible for staffing. I would like to know if any of those nurses there do anything in terms of nursing anymore. My bet is they're mostly directors. Is that right? So you've got directors coming out of your ears, and people doing the work is what you need. And the people doing the actual work should have more of an input into what is happening here. And I want to see that happen there. You guys need to get your voices heard and heard well. And I congratulate you for doing this tonight and wish you all the best.
I've attempted to do some homework on this, so I called up a person who had run for political office last fall in Berkshire County. I won't say what level or even what sex that person was because I don't have the permission to give it as an identifiable quotation. But this person said, this person had a letter in the Berkshire Eagle in support of the nurses without being confrontational, adversarial towards BHS management. And this person told me that they got a call from a top administrator who was the one in their team who knew this person, asking him where that information was that this person had gotten, but then close out phone call by saying, if you run for political office again, we will remember this. And I thought that was kind of chilling.
Hi, I'm Karen Rogers. I've worked at Berkshire Medical Center for about 34 years, and most presently at Crane Center. And I have to say that we don't feel the crunch, that we don't feel the pinch of staffing in the manner that they do on the floors every day, but we are 100% supportive of them. One thing that I didn't hear tonight was, which I've heard a lot on the radio, which addressed the salary issue. And although we've talked about a 1%, 2% proposal from management, equaling 10% over that 3 years because of step increases, being top of scale, I will never see the 10% that they speak of. And they have also proposed that we increase our insurance to double what we're paying right now for insurance. So what that means is that at the end of the day, and forgive me, but my expectation is that I would just hope that it wasn't unreasonable to get the same salary that I did today or tomorrow as I did today or a year ago. And what that would look like is that under their proposal, we would actually end up making less take home than we do right now. So in light of everything else that's been going on, and truly we are supportive of that staffing situation, we are feeling that pinch, and that salary that we talk, that the administration has talked about on the radio in their advertisements is not something that we're going to feel. In fact, we're going to feel a negative. And I know that that is not our big issue, but it's something to think about in this time where in the last 3 weeks the gas has gone up, exponentially, and it's just something that we all want to consider as well. Thank you.
All right, well, it is about 8 o'clock, and I would like to thank everyone for coming out tonight, and just take a little bit of prerogative, personal prerogative here. When we stand together, be it for our teachers, our nurses, our state workers, we have power. I would think, and this is just my own opinion here, but I think BMC is fairly scared because the disinformation campaign has escalated over the summer. And I just want to thank everyone who is a nurse, who works hard every day, and I'm sorry you're having to go through this. It's not right, but I think many of us will be with you no matter what. So thank you again, and support your nurses.